Hello, and welcome to another episode of David's Divergent Discussions. I'm your host, David Gray Hammond, and here with me tonight, once again, is Katie Munday. We're going to be talking about Katie's research into, is it equality in cancer treatment?
It's like cancer service inequity, inaccessibility. It's a bit of everything.
So it'll be an interesting one, if not with the potential to be a bit triggering here and there. So do be warned that, we're talking about cancer. It's not like the topic that everyone wants to be talking about, but it's a topic that needs talking about. And I think, talking about disabled people's access to services for cancer is a very important thing. Anyway, I'll start with a brief audio description. So my name's David Gray Hammond. I'm a mid-30s white Mediterranean male. I'm wearing sunglasses. I have a shaved head, a beard, a lip piercing, and an ear stretcher that you can't really see on the camera. And I have a new bookcase that I built. I'm quite proud of that. This one's considerably less rickety than the other one. I still need to anchor it to the wall, though. Cue the next 15 live streams of Katie asking me to please
secure that yet? Has your little boy climbed up that yet? Yeah, that's what we need to worry
about. Not yet, but he will climb up it because he climbs up everything. So it definitely needs securing to the wall. Katie, would you like to do a brief audio description?
Yeah, I was just saying to David before I came on that I'm almost in like kind of black and white tonight because I've only got one light on in the front room. Having issues with light in this room at the moment, so that's why I'm a bit black and white today. You can't really tell the color of anything I'm wearing, but I'm just sat here in like usual pajama type business. I got my big glasses on, sat in my usual seat in the front room, in front of some old curtains, my green curtains. If you've been watching for a long time, that's a joke from Academy. I'm Simon with my old lady curtains. And I've actually finally got my hair cut. So I got short back and sides. It's a bit messy on top, but I'm loving it. Fantastic. Feeling
cute. Okay, well, cancer inequity. Where do we start, Katie? Do you want to paint the picture for us?
Yes. So for the last 2 years, I've been working on cancer service inequity projects, which are under Wessex Cancer Alliance, the National Institute of Health Research, Help and Care, and with help from Bournemouth University as well. And it's funded by Macmillan, and it's part of their long-term program of work called Whatever It Takes. And basically that work is to do with having conversations with and doing kind of co-productive workshops with lots of different what they call underserved populations. So I'm involved in the disability one. I'm also involved in the Trans Plus project. And there's a global majority one. I think there's a Black person specific one as well. I know they're doing an unhoused project. So I don't know how many projects they've got planned for the next couple of years, but that's the kind of work we're looking at. So we're looking at people's experiences of cancer services. So not just diagnosis and treatment, although of course that's a really important part of it as well, but anything from, this is information I found on the NHS website. This is a poster I saw in my GP's office. I got a letter from my GP to come in for scanning, and if I did or didn't go, and these are the reason why. Through to experiences of going in for screening, diagnosis, treatment, aftercare, and any support throughout any of that. So we're talking really global kind of idea of cancer services in the UK. And the point of it is Surprising absolutely nobody whatsoever that healthcare is not accessible and equitable to all people, especially marginalised people, of course. And the more marginalisations you have, the harder it is to access things. And cancer care. I wouldn't like to think that any part of healthcare is more important than the other, but cancer care is obviously extremely specialist. Is exceedingly worrying, very scary illness to have. So I'm not negating any other experiences, but that's that's why this project is going on. So I don't know if I want to talk about the research too much, although hopefully we'll add a link to that later in case anyone's like into research and wants to know about that. But I know that that's not everyone's cup of tea. But just as an overall summary, basically it was doing craft-based or creative artwork-based workshops with people. So we spoke to a multiple sclerosis group, a group with lipedema and lipedema, an autism group, obviously, and also a blind and visually impaired group, and had a phenomenal conversation with someone from the Royal National Institute of Blind People as well, who was just, blatantly my kind of person. Going through her own kind of breast cancer care at the moment. So she had a lot of very interesting things to say, but also a lot of very sad and a lot of very powerful things to say about how she's been treated as an older person, as a widow, so all these kind of different intersections came into play throughout talking to all these different people. And the next part of the study is to do with, we've literally only just started it, is to go back to these groups of people and say, right, okay, so we've got an understanding of what some of your cancer service experiences are. How do we make it better and create basically resources together to go into the voluntary sector and to NHS and basically train, share resources, whatever, to make patient experience just like a million times better, hopefully. So that's the general plan. And something very similar with the Trans Plus cancer service project as well. But we're actually using, so in the disability project, we used, hopefully this is quite clear on screen, hopefully. We basically created handprints. So you can see all the different handprints on there. Because we thought it was relatively accessible to people. Very large versions for the blind and visually impaired people. You could draw around hands. We had hands that were all ready to go. I mean, some people there's like a strange little cute owl creature and love hearts and all sorts of different things. The feathers went down very, very well. So we just like mixed media stuff, boom, like just kind of do whatever you want, really. And a really powerful one there was someone from the blind and visually impaired group that we worked with, who had actually snipped into one of the fingers on his drawing and then made it quite tactile. And he told me that represents my scars from my brain surgery. So he's got quite large scars on his head from his brain surgery. So some really powerful stuff, and very tactile as well, which is a really important thing working with blind and visually impaired people. Like making art that isn't accessible for blind and visually impaired people would be pretty poor. And with the Trans Plus work, we're actually doing small. Oh, I wish I'd brought mine down actually. Light pink, light blue, and white squares for people to embroider on, stick things on, write their story on, however it is they want to share things on there, and basically going to create a ridiculously large trans flag that will hopefully go on a bit of a tour, actually. So that would be be quite amazing before we start then making resources, hopefully with the same trans plus and gender diverse people. So that's the kind of very snapshot of what we've been up to.
And I think, you mentioned marginalized people. It's important to put this in perspective here, because obviously this is David's divergent discussions. We talk about neurodivergence. Neurodivergent people and people who experience disability in general, but obviously for the purposes of this, neurodivergent people, we often do find that healthcare, we don't have equal access to it. I've talked a lot about the fact that we experience pain differently, and doctors don't take that different way seriously.
Mhm.
We're either perceived to not be in enough pain, or we're perceived to be in too much pain. It's a significant failing. The whole system is quite inaccessible as well, I find. I know for me, going through mental health treatment and substance use treatment, the way that those health services was set up made it very difficult to engage with them with my particular flavors of neurodivergence. And I don't know, do you think this is something else that comes out in cancer services? The services themselves are not set up in a way that works well with our neurodivergence.
Yes, 100%. In fact, I've got some quotes. I wasn't organized enough, so yeah, I just wanted to share before we get cracking on what people have said. If you think your loved one has cancer, you need to contact your GP immediately. And I've shared some links there of just kind of different resources. There's a lot. Thankfully, there is a lot of stuff down that is easy read. That has like quite a lot of pictures. That can be downloaded, printed out if you need it to be bigger or with fewer colors and stuff like that. So accessibility, especially within the volunteer sector, seems to be going in the right direction anyways. But what I wanted to share about what you've just asked, David, is there was an autistic person who shared about her experiences. And this was her asking about talking about going in for a smear or a cervical screening. And she said, I wouldn't feel able to say anything during the smear or say stop unless the nurse had specifically said I could speak or say stop. If their tone is rubbish, I wouldn't dare say anything.
Yeah.
So I think that very much encapsulates definitely a part of that, around being very specific in how we need to be told things. And that's not just for neurodivergent people, that's for a lot of different people. If you feel like you can't say no, or you can't stop things, or you're not quite sure whether you can or not, that's a real kind of concern around consent, really.
Yeah, it kind of raises that question of healthcare being something that's done to you versus something you access when you need. Because I mean, let's be completely honest, healthcare without consent is assault. Especially when we're talking about things like cancer, the investigations, the treatments, they are very invasive. So if you take that element of consent out, what you're talking about is really something quite traumatizing.
In fact, I'm just writing that about healthcare not being something that is done to you. I found that really, really interesting. There was another person. So we had some of the printed out hands in case you didn't want to draw around your own hands. And as soon as they came out of our art supply things, someone this again was from the autistic group of people that we spoke to, held up the hand and said, "Don't touch me, doctor." And I thought, oh my goodness, isn't that exceedingly telling?
Yeah.
And someone I would say was probably in their 50s. So he's probably had quite a lot of interactions with GPs and other healthcare professionals. So yeah, that's a concern. That's a definite worry, but not just for cancer care, but across all kinds of healthcare, and social care too. Actually, not just healthcare. So I don't think that, to actually answer your question, I don't think that cancer services, for the main part, are set up for disabled and or neurodivergent people. Another person was talking about how they're a wheelchair user and going in for a mammogram, and she wasn't able to weight bear, but basically no one was really helping her with it. So she got an incomplete scan, and then was told that basically her carer would have to check her. So yeah, like, I don't understand why a carer would have to have that responsibility. And would she be happy for her carer to have that responsibility? Would the carer be happy to have that responsibility? When all that's needed really to do a mammogram in an accessible way for someone who needs to sit down whilst they're having it done is for it to be lower down. And now these things do exist, but they exist in, 2 counties over, or 5 hours away and stuff like that. So to go in to be asked to a screening that you are really undignified in the way that you can engage in it, or people were talking about being relatively manhandled whilst going in for colonoscopies. The other community researcher on the team has those regularly as well. She won't mind me saying that, because she has Crohn's disease, and she said, yeah, it can be really, really brutal, really, really brutal. And someone was saying about basically having their face crushed up against the glass whilst they're having their colonoscopy done.
Yeah.
So
I
if you're already in there for being worried about things, or you get to a certain age and you have to go in for screening, and then it's really undignified, painful, you're getting a bit, I think people use the word manhandled quite a lot. And then you come out with an incomplete scan. The likelihood of people going in for that again,
yeah.
quite unlikely.
Yeah.
And it may be those very worries about that happening again, or even if it's not happened before, that kind of, if a lot of these groups that we went to were support groups, not for cancer, but like support and buddy groups, disabled specific groups. So if you heard that your friend Linda from your autism group has had trouble with going in for scans, then you might not either.
And I do have a response to that. But remember, if you're watching live, you can chime in the comments with your own take on what we're talking about, and we can see your comments in real time. But what you were saying about, the person having the mammogram and they couldn't weight bear, so they were told their carer would just have to check them. I find that incredibly telling, because where would you see that being done to an able-bodied person? Where would you see that being done to a person who is not experiencing disability or part of a marginalized group? Because I think, there is this attitude that, well, if disabled people can't access it, then that's their problem, not ours. But it's not. It's everyone's problem when disabled people can't access services. We talk about an overburdened NHS. Well, if disabled people are unable to access cancer screening services, that's going to, take a lot more resources for the NHS to deal with later down the line, not to mention the impact it has on the family. And, we're talking not just the impact of the cancer, but all the fallout from that, mental health, so now there's other services involved, and sometimes I just see, discrimination in one area of healthcare can lead to so many other things having to be brought in to fix the problem. But so often we are expected to fix our own problems as disabled people. And I think it comes to this sort of neoliberal attitude that, we should be self-reliant and, yes, the services exist, but be frugal with them. And I find it really problematic that services will, sort of just dismiss us because we can't access it in the way they want us to.
Yeah, 100%. It's a one size fits all that doesn't tend to fit really anybody. And there's also this, so across the different groups, we probably spoke to about 45 odd people, and there was always this constant belief that because you're a disabled and neurodivergent person, that you therefore have a carer or you have some kind of support network. And loads of these people were saying, well, no, I don't have a carer. No, I don't, I'm estranged from my family, or I live alone. Some of the kind of people in their 70s and 80s that we were talking to from the lymphedema and lipedema group, not only did they not have someone to support them, but actually some of them were caring for their spouses as well. So, this kind of idea that you have someone to be able to do that for you, and that they're therefore happy to do it as well. I mean, we saw there were similar things for some of the visually impaired people we spoke to, about when you have to give a poo sample as part of your kind of colon screening. Now, I don't know if you've ever seen one of those that you've got to be able to put some of your specimen in, but it's basically quite a long, thin plastic tube with a little screw top. And you've got to be able to get some stuff in there, right? Not a nice thing for anyone to be able to do. If you're blind or visually impaired, how am I getting that in that tube?
Yeah.
And again, the answer was get someone to help you with it. Okay, how massively undignified and disgusting for everybody involved. And what if I live alone? Who am I? What should I ask my neighbour? Like, and then I think on the underside of that as well, if people there's several things to the kind of carer aspect as well, is that most cases carers are women. Most cases they're unpaid, or if they're part of social care or something like that, very poorly paid jobs. So it's just interesting that these responsibilities are somehow being brushed off to people who are either unpaid carers or very poorly paid carers, and very likely women. It's just a very interesting thing that I think about. That wasn't necessarily brought up with participants, but as something I was been thinking about since.
Something that stands out to me as well, because I've been thinking a lot, obviously, in my writing work about, autistic families, and the fact that, as an autistic adult, you've likely had to fight various systems throughout childhood, adolescence, young adulthood. You then have your own child who almost inevitably is neurodivergent themselves, which throws you back into fighting that system for your child. If you then find out you've got cancer and have to fight an inequitable system to survive, on top of fighting, like, there's so many layers to how this builds up and builds up, because this is one of the things we have to, because I think sometimes people forget when a person has cancer, that's not their entire life. There is a world that goes on around them, and I think sometimes we forget that. I mean, so many times I've known quite a few people with cancer, and the number of times they've been reduced to the person with cancer when actually there is so many other things going on in their life alongside that. And it worries me that these services cause us to have to fight to access these services, or to give up our dignity to access these services. I'm aware someone in the comments, I haven't shared it because I don't know if they're comfortable for me to pin it to the screen, but someone in the comments has mentioned that they have cancer and they're neurodivergent, and they've actually ended up trying to discharge themselves from treatment because of the stress. It's not easy being neurodivergent on like a normal day. Like,
by the way, that person can get in contact with me if they want to. I don't take messages on my Facebook anymore, but I'm on Twitter. Maybe I can share my email address at the end of this, because we might be able to get some help, or perhaps even talking about it might be helpful in itself. So I don't want to just leave that person kind of, feeling really, really stressed out if we can help in some way. So please do that.
Okay. So we've talked sort of, about the accessibility of services, and in a real world sense, the realities of just doing the screenings and doing the investigations and doing the treatments. Were there any other sort of particular themes that came out? I guess I'm wondering if there were any themes that came out around like the actual experience in day-to-day life, not just the
Well, yeah, not necessarily, because we were specifically talking cancer services and experiences of cancer services. Although having said that, we spoke about all sorts of different things whilst we were there. And age came up quite a lot. So this idea that one of the attendees from the blind and visually impaired group we spoke to, he was probably in his early 20s, and people would say to him, "You're too young to be blind."
That's not how blindness works.
What does that what does that mean? And then would get out of an accessible space with someone, obviously someone else having driven him and stuff, and people just looking at him a bit funny because or being confrontational about the fact that he shouldn't be using an accessible space, or that they thought that he shouldn't be using an accessible space. And then saw on the flip side of that, just like really ageist things said to people when they go in for various different things. So the person who I spoke to from the Royal National Institute of Blind People said that I believe she's in her 60s or 70s, and was basically told that we could do a tummy tuck for you at the same time if you wanted, seeing as we're doing your breasts as well.
Wow, that is dreadful.
Yeah, so that was a joke from a practitioner, and she was not impressed with that. And I have a feeling the practitioner got told that she was not impressed with that. And I completely and utterly appreciate that. Like, what is that? Why on earth would you say something like that? Why would you body shame someone whilst they're going through their most painful and scary and quite lonely journey? It's just beyond ridiculous. And some of the people, there was a lovely person from the lymphedema group who was going on about the fact that I think he was 75, and he was saying that basically if his cancer comes back, the hospital was saying if your cancer comes back, we're not going to do anything because 75, kind of getting on a bit. And it's like, but I still want to live. Like, I don't, how comes people get to decide that 75 is the age that I'm not allowed to have pain relief, care, support, treatment? the NHS that I've been paying into for the whole of my life. So yeah, a lot of ageism around stuff, people being carers whilst also going through cancer was something that came up, which I wasn't expecting to come up actually, but came up quite a few times for various different disabled people as well. And then being a carer, it came up quite a lot in the lymphedema and lipedema group. So some of the people who were there at the group had lymphedema because of cancer. So lymphedema and lipedema, very, very quickly. I'm not a medical practitioner. I should have said that at the beginning. I'm not a clinician, but lymphedema and lipedema is issue with your lymph nodes, which basically means that your joints can inflare and you get a lot of water and fluid build up, especially in your extremities, so in your arms and in your legs. It's exceedingly painful. Really, really, and many other symptoms besides. But if anyone's sitting here thinking, "Oh, what's lymphedema?" But sometimes that can be also a symptom of having had cancer or having cancer, or having treatment for cancer as well. So half of the group-ish that we were speaking to had lymphedema or lipedema because of having had cancer, and the other half had it for various other reasons. You're more at risk if you have diabetes and you're older, and kind of various other things like that. So when we were talking to people who had cancer, then had lymphedema, and were also caring for their spouse who had dementia or physical disability and stuff like that, we just think how hard these lives are, with no support. Like I was saying about unpaid care earlier, like no support. So it must be quite isolating, it must be quite lonely. But I'm really glad for the people that we went to the groups for, that they had the groups, because they were massive support to each other, but not just with living with lymphedema and lipedema, or being autistic, or being blind and visually impaired. Of course, all of those things as well, or having MS, but also just as a way to socialise, to have fun, to get out of the house, to be in a safe space, to be able to share information. I mean, that was one of the big things that came up. In fact, I shall read you our themes. We had 8 of them. It was impossible to trim it down any further, if I'm honest with you. But the way that we wrote them was basically from if it was being said by one of the attendees. So I felt inappropriate assumptions made about me affected the quality of my care. I felt unsafe during my cancer journey. I could not physically access services. I feel that information about my healthcare is not accessible for me. I feel isolated and lonely. I felt like I constantly had to advocate for myself because no one was listening to me. I felt like there were multiple issues compounding my access to cancer services. I feel like there is a resistance to change and adaptation to support me. So yeah, pretty strong stuff.
No one should feel like that at any point, let alone when they're going through cancer. But one thing I wanted to ask you was, did you have much input from learning disabled people? Because I feel like that's a group that gets left out of the conversation more often than people are comfortable to admit.
I'm glad you've asked that, David. Dun, 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 because we will be this time. Because that particular arm part of the project was the pilot scheme. So that was Macmillan going, we know that cancer service inequity exists for disabled people. Here's some money and a little bit of a plan, and off you go. So so we had all these plans to do like a 6 or 7 week course with the same people in a kind of group of mixed disabilities and stuff like that. So it basically the groups ended up being who myself and Rosie's the other community researcher, Kate and Stevie from Bournemouth University, and Amanda, who's our clinical nurse specialist, who's fantastic. So it was groups that we had a connection with, had worked with before, or so my connection was kind of to Autism Hampshire, which I've worked with before and been along to as a member as well, and various other groups like that. So now we're starting the second leg, which is the production of resources. We wanted to, so we've asked all the groups that we'd been with before. Most of them were interested, which is fantastic. But we've got more space to have other groups, which is fantastic. And actually, exactly what you've just said just there, I said to our bosses at Help and Care, we have to have a learning disability group. Like, we just have to have a learning disability group. I find, like, in research, learning disability, deaf and hard of hearing people and blind and visually impaired people are just massively just not spoken to, or have people around them spoken to. The same kind of thing in autism research. So yes, learning disabled people will definitely be a group of people we are working with this time. In fact, it might even be 2 groups. We're working with a different visually impaired group. I think we're working with the lymphedema and lipedema group, which would be fantastic. Autism group will be back to again, I'm sure. It might actually be a different group within the autism group. So yeah, that's definitely a thing for me. And also when you go to some groups as well, there were definitely neurodivergent people at the blind and visually impaired group that we went to. Whether they knew that or not, I don't know, but there certainly were. So we all kind of mix in together anyways, didn't they? But yeah, no, it's a really, really good point and something we're working on. But if anyone's watching this today saying, why aren't you working with this group? Why is this group would be really useful? This would, like, please email me. We are into it, because there's no point. The work isn't some kind of tick box exercise. This is, we want to make something of this.
And whilst we're on the topic, where can people email you?
Just my usual email, autisticltd@outlook.co.uk. Am I a .com? I'm looking at Jay. Jay don't know.
Your website is .co.uk, if that helps.
Oh man, I don't know.
I see you put the link for the Cancer Service Accessibility Report there. So if anyone wants to go and have a look at that, it's on Katie's website at autisticltd.co.uk. I do like the fact that you tend to make your research work quite accessible. I've seen you do easy read versions of things and stuff like that, which I think is really good, because sometimes I think people can get a bit lost in the academic talk.
Yeah, or don't have time for it. If we want, accessibility is definitely a key thing for me as much as I can. Again, I'm open for people saying, "Oh, that's a bit interesting," or "Why haven't you done that?" or "Why have you done this?" But also, like, if we really, really want professionals to read stuff or be able to have something they can keep coming back to, is that sometimes it actually just really needs to be short, snappy bullet points. Because the NHS staff are completely and utterly overrun. Like, there's no way going around that. There should be, but there isn't. So if it makes it easy for anybody, then let's do it. Why wouldn't you do that? Very much into images as well. We've got a few videos on there. So I have put my email address in the comments.
Fantastic. So anyone who wants to contact Katie can do so at autistic_ltd@outlook.com. And
I
it's on
very
the
nearly
screen.
got it correct.
Yes, it's on the screen now for anyone who's watching this in video format.
Yeah, very nearly. But if you go through to my website, you'll find me. You'll find me. I'm there. I'm everywhere.
So is there anything that we haven't covered about this evening that you are really wanting to share with us?
I'd like to share a bit more about what people actually said.
Yeah, let's do
But
that.
I haven't necessarily. I have the research report in front of me. So I haven't. There's also like a really. I was open and ahhing about sharing it today. There's a video on YouTube. So if people go to the link that I've put in from Autistic Ltd, my website, you'll be able to come to YouTube, which shares loads of the attendees' verbatim quotes in a video. It's really, really powerful stuff. But I just wanted to share just a little bit from in the report. If I find the right page, because the first theme, I think it was the first theme, anyways. I felt that information about healthcare is not accessible to me. I think that was the second theme actually, but that came up all the time.
Yeah.
So like blind and visually impaired people would be like, I can't read this because it's in a strange font, or my screen, my reading device on my phone or my tablet can't pick it up because within the pamphlet you've given me, it's all in text boxes. And a lot of those kind of apps and stuff can't I don't know the technological thing, but the app stresses out and can't work out the text because it's in a text box.
Yeah.
So it's just small stuff like that. So could you print me off a plain version? Could you print it off in, 18 font, 20 font, something like that, or change the font on it and stuff like that. And even when blind and visually impaired people were going in for optometry stuff and like eye-based care, even in there, oh no, we can't print that any bigger. You're literally an eye care ward.
Yeah.
What?
That's really
What do you mean you can't print it in large? Like, just beyond ridiculous. So I thought I'd share a few other things as well. This is really powerful. I realized I made decisions without having all the information I needed to make the decision. For example, no one told me that I would lose my sex drive during chemo, and as a result, I became depressed. It was a very difficult time.
I think that's an important one as well, because I feel like doctors probably don't raise these things with disabled people, because there are some perceptions that when you're disabled, that sex is just off the table.
And I will also say that this person had cancer in her 50s, 60s.
Yeah.
So I have a feeling that.
So it's not just the disability there either. There's the age and the assumption of, well, you're past it.
You're not having sex anymore.
Yeah.
Okay. Yeah. I made a visit to the ward prior to surgery to prepare and gather information, but all papers provided were unreadable to me. Nothing comes in large print, and accessible websites are often not actually accessible. Oh, yeah, that came up a lot. That did. I'd have the screening if they didn't make it so hard to arrange. People were talking about telephone lines and how that wasn't always easy. Interestingly enough, someone else also spoke about how everything going on to apps or online booking and stuff actually wasn't helpful to a lot of people, which I fully appreciate. But she was saying that basically she feels like she's being left behind, and a great deal of people are. I think she was alluding to kind of older people, but I would certainly fit in that category, even though I'm in my 30s. like app-based
Well,
booking. And you've got to remember this password, and you've got to remember your NHS number, and you've got to know your
I mean,
inside leg
it's
measurement.
not
No.
it's not cancer related, but like apps. I know when the mother of my child was pregnant with my son, um, everything was done on apps. They didn't do it with paper records anymore. But the problem was, if the professional didn't upload the thing to the app, you just didn't have
Mm,
it.
mm. Yeah,
Like,
they were just bringing
you
that
know,
in after I had little man. Yeah.
like so I feel like that there is a move in healthcare to move things onto apps, but I don't feel like there's necessarily the infrastructure in
Mm,
place to make those apps
mm, mm,
work or be accessible to people.
mm. And these things are only as good as you say, as the information that you put on them. So if you've got
Yeah,
your maternity app or your pregnancy app and no one's putting any of your information or your scans or your anything else on there, then yeah, it's not particularly useful.
oh
Is it?
yeah, and the NHS app itself, I know there's that patient knows best section where you can upload your own test results, and I'm like, I can barely log into this app. How am I supposed to upload my own test results? I don't know what they are, for starters. I'm waiting for you to tell me.
Yeah, it's weird. So you know how we were
Yeah,
talking about earlier how it's putting it back on patients or potential patients to have to do their own care. Like
yeah,
similar, right? Yeah, yeah,
yeah.
100%. Um, oh, this was so under I felt lonely and isolated. My treatment was like a cloak of being looked after for 8 months. A cloak of being looked after, told what to do, and sent from here to there. Then on the last day of radiotherapy, it was by, and that was it. There was nothing. I was left alone in the wilderness. No one wanted to know me anymore. I was alone with my cancer. I had struggled with my disabilities at the best of time, and now, on top of that, cancer felt impossible. Oh, yeah, talking about caring responsibilities, caring for my sick husband meant I had to do heavy work, and this seemed to trigger my lymphedema about 6 years after my treatment. I'm sure that was why I got lymphedema. There was no choice. I've also had cellulitis twice, but I have to care and do all the household jobs. Um,
Cellulitis is nasty
yeah.
as well. I've had that a few times, but
Mm.
yeah.
And this was interesting. Someone brought up COVID should have made people more caring towards others, but people have become more selfish. COVID has made people less tolerant. Well, that was um, really interesting. Whether most people would agree with that, with the kind of do not resuscitate for disabled people and neurodivergent people. I definitely know.
Mm,
I mean, it could have been an effect for all of the people we spoke to, as well as Rosie and I as community researchers. But there were definitely people within those groups that would have been more vulnerable to that than others. 100%.
yeah.
Um,
Mm,
yeah, so if you were going in for cancer services during COVID, so again, not necessarily connected, but whilst you were talking about kind of pregnancy, me going into the hospital around all the changing COVID policies and practices, and um, you didn't know what you were walking into in the hospital. And I had to go in twice a week, not twice a week, sorry, every 2 weeks, towards the end of my pregnancy because I had gestational diabetes. And, just basically had a meltdown in the reception area because Jay can go up with me, my husband can go up with me. Yeah, and it was just, um, yeah, what that would be like for other people going in for all sorts of care, all sorts of healthcare. But if you were also going in for cancer care, and also the risk of, even if you were going for even if you were visiting the hospital for other reasons, but were still undergoing aftercare from your cancer, radiotherapy, chemotherapy, whatever you've been through. Obviously, the immense risk of getting COVID. Um, on top of cancer and having immunosuppressant kind of situation. Sorry, it's getting to the time of the evening where I don't have any words anymore. But it's putting people in a really vulnerable state, and not just physically. As the person shared with us in the comments earlier, it's not just a physical state; it's also an emotional state. It's scary, it's horrifying. It changes your whole entire body, and and you see who are your real friends and aren't your real friends, and these people that you think might be supportive aren't quite as supportive as you thought they might be. And so it's not just a change in your body and a change in your physical health, but that can massively change, and having long bouts of time off due to sickness. And now legally in the UK, people obviously can't fire you for stuff like that, but that doesn't mean they'll make it easy for you when you go back.
Yeah, and I think to piggyback on your point, services feel quite intolerant since COVID. They the demand for those services has skyrocketed as the world has, I say in inverted commas, returned to normal, because it's not really there yet. But as things have reopened, let's say, and people have started re-engaging with the world and wider society again, these services are under huge amounts of strain to try and catch up on backlogs and all sorts, and increases in demand. And rather than upskill staff and increase the number of staff on payroll and do things to improve the basic structure of the service, they've kind of just been left as they are, with a massive increase in demand. Some services have even been cut from what they were doing. And it's no surprise, really, when you have staff who are so stressed they don't have time to give you the time of day. Don't get me wrong, there's more to it, because you do get professionals in services who really shouldn't be there. But I think we have to be honest and say that a lot of the problem is to do with the fact that as the demand went up, the ability for that service to cope has been criminally under-resourced. And it threatens lives, because we're talking about cancer services here. If people can't access those, that can have very real and life-threatening consequences.
Yeah, 100%, 100%. But what I will say to that is I think that things are changing in healthcare in general, and social care, and in cancer care too. Things are becoming more accessible to people. Like, I would say that most of the practitioners and professionals working, well, at least in my experience anyways, within hospitals, GPs, stuff like that, are quite caring individuals. And they understand that people don't just exist as a sick person, as an unwell person. Like, there's much more to people than that. And some people will be better than that than others. So I think that the policy is very slowly changing. It's not changing at the rate it should be. But it is slowly understanding. There's we see this in trans healthcare as well. Like, there's a lot of autistic and otherwise neurodivergent people who come through here. Maybe we need to change out the way that we make things accessible to people. That doesn't mean that they always get it right. It doesn't mean that what works for one autistic person works for all autistic people. And the same with disability, of course, as well. But I think it's going in the right direction. The fact that Macmillan, which is one of the biggest cancer charities in the UK, is looking into things like this, and spending significant money and time on stuff like this, and not just it being, in my mind anyways, a tokenistic thing. They've decided to use people from the community like me and Rosie, to do work with other disabled people. There's 4 trans people on the Trans Plus project, so it's not it's relatively well thought out. It's not just like, oh, we're just going to harvest information from these people and perhaps just probably stick it in a drawer somewhere after we've gone, oh, isn't this a bit strange? Love it or hate it, the kind of McGowan, I cannot remember her first name, the McGowan training for autism and learning disability.
Okay.
Is
Yeah.
it Karen? Is she a Karen? Paula, sorry, yeah, that's it. Love it or hate it, it's all going in the right kind of direction. And I say hate it or be unsure about it just because of how many autistic people were actually involved in creating it. That's all I mean by that. And I think we have a right to be wary of stuff like that. Like 100% have a right to historically speaking, not just Paula's thing. Any kind of research. I had an awful lot of questions about how things would work before I got involved in these projects, because I didn't want to get myself involved in something that was tokenistic or
Yeah.
but I think it is very, very slowly getting there. I mean, just and also with LGBT QIA plus people's experiences of cancer. That was one of the links I shared earlier. We now have a LGBTQIA plus or specific cancer charity in the UK now called Outpatients, and they're fantastic. And they do stuff around, a campaign around what's best for my chest, around going in for mammograms and various other things, and how to get the right treatment as a trans person, kind of stuff like that. So these things, and I have no doubt that in other communities, various other things that I probably won't know anything about or shouldn't have access to or whatever, but I'm sure it exists. So I think we're getting there is what I'd like to think anyway. So.
Well, were there any more any more quotes you wanted to read to us? Because I'm aware we're getting towards the end of the hour.
Mm-hmm.
So if there's any more quotes you wanted to read, now would be the time to do so.
Now would be the time to do it. Hurry up. Let me have a look. What I will say, whilst I'm having a little look for that as well, is that in case anyone was watching or listening to this and thought, what would be the thing that I get out of it? If I'm a person who's experienced cancer services or have had cancer or cancer treatment, what would kind of be the benefit of me doing work like this? And I've got to be honest with you, like, although we were talking about really serious stuff, really quite painful things, we also enjoyed it. We had a lot of laughs. It was really cathartic for a lot of people. It was really good for Rosie and I to be in the room, because then we can be like, I've had that experience as well, or I feel that inaccessibility, or going on about the blue badge and looking too young to use the blue badge and all of this kind of stuff. So we enjoyed it, if that doesn't sound peculiar. And all of the groups we went to said, when can you come back? When are we doing this again? Let's have you back. And now we're working with them again. And I suppose instead of finding a quote, I think what I'd like to do more than anything is just, I mean, we say it everywhere we write about it, but like to just thank the people again who have shared their stories with us. Like, this is powerful stuff. And some of their stories, some of their things got shared at the all-party parliamentary group on cancer. We went there in November, talking about inequality in cancer services and cancer care. And we're doing various other things with these, and resources and training is the end game, and policy changing is the absolute end game, and let's make things accessible for as many people as possible, basically, is where we're at. But I wanted to thank everyone who shared their time with us. Yeah.
And I think it's really powerful when people get to share their own stories, because when you think about the narratives around marginalized communities, there is a lot of control placed in the hands of the privileged few over what stories get told. But realistically, when we tell our own stories, we're reclaiming that narrative. We are writing what it means to be disabled, to be trans, to be black, to be any marginalized group. We are using our physical presence to write a new meaning for those things. And I think that's really powerful. And I think, we need a lot more projects like this one looking at various other aspects of marginalized life, because, I think so many people get bogged down in one aspect of our identity that they forget, much like I said earlier, where people will forget that a cancer patient is more than a cancer patient. Well, when you're disabled, people forget that you have a life around that disability. When you are trans, you have a life. Like, don't get me wrong, like, autism for me is kind of like almost my whole identity. I talk about it, I think about it almost constantly. But, I'm a father, I'm a son, I write poetry mostly just for myself. There's things that I do that aren't necessarily directly related to my marginalized identity. And I think projects like this are really powerful because they show you a human side to what is so often reduced to numbers and statistics.
Yeah, and I think that's kind of like an upwards thing in health research as well, is that health research historically has always been very quantitative driven. It's been data, numbers. How many people had this then? What does it look like now over the lifespan? All of this kind of thing. And that's useful. That gives us a lot of really useful information, but it doesn't contextualize things.
Yeah.
So demographics is very useful, and that kind of data is very useful, but I think health research is going further into narrative type work, which is my kind of thing. I just wanted to add something as well, because I know that Shah Goodwin, who's an autistic person who's had cancer, and is part of a team in the University of Exeter, and that they are currently they're doing a 3-year-long project on autistic people's experiences of breast cancer care, diagnosis and care, and they're doing that with breast cancer now. I know they're looking for people with lived experiences on their advisory board, which would be a paid role. So I just wanted to kind of put that out there as well. Like, when you start on projects like this, you think you kind of have a feeling that you might just be on your own, and then you connect with other people and you think, there's other people that are doing really good, meaningful work out there that is also based on lived experience, but not just within the people that we're talking to, but the people who are talking to these people or advising. So co-production isn't just a cute name. It's kind of happening as well, which is fantastic.
Okay, well, thank you as always, Katie, for a very good episode. It's certainly, there's a lot to take away from this, and I have a funny feeling we're probably going to do a part 2 on this one at some point, especially as the project is still ongoing. There will be no doubt more to talk about, more to highlight. For anyone who's watching, please feel free to visit the link on screen. You can find my my Android app, because I turned my website into an Android app. That was one of the many things I did when I should have been doing other things like writing book chapters.
Yeah,
Yeah. Yeah, you'd be amazed how much of the content I create because I'm avoiding doing something I'm supposed to be doing.
I don't think I would be amazed by it, actually, because I think the answer is about 90%.
You wouldn't be amazed because you know me quite well at this point, but people who don't know me quite well would be amazed. So let's keep the mystery alive.
Oh, okay. No, he's very well adjusted, people.
Yeah.
Yeah, he's very well adjusted.
So yeah, you can find links to most of my stuff, like my books, my Android app, at linktree/emergent divergence. It's spelled linktr.ee. There's no easy way of spelling that out, so hopefully people will look it up, and I'll put links and stuff in the description for the podcast version of this and that. But I will grab some links off of Katie before I let them go, so that I can throw those into the description section of the podcast. And no doubt you'll be back again, Katie, because I haven't told anyone yet, but Katie did agree to be my co-host for this because Katie is here so often. And I like doing lives with Katie. Katie's good people.
That's nice.
So yeah, thank you everyone who's tuned in. There's been quite a lot of you tonight, actually, because not many of you responded to the event, but there's been loads of you watching, which is really nice.
Perfect. Good.
Yeah, on Thursday, for people on TikTok at 8 p.m, Tanya Adkin and I are going live on TikTok to do a monotropism Q&A. And on the 22nd of March, I have Rachel Gavin coming back on here, and we're going to be talking about neurodivergence and learning disability. So that will be a good one, because, as I said earlier, learning disability does not get enough coverage. So thank you, everyone. I'm going to put the outro video, it's not really a video, but the outro video up, and that'll be the end of it. So I will see you all on the other side. Take care.
Bye.